Good afternoon. Dr. Vijaylakshmi is the professor and head of biochemistry in Mallar Reddy Medical College for Women, Hyderabad. She is a dedicated professionally teaching biochemist for the past 20 years. She is an NABL lead assessor and technical assessor, having experience in designing and establishing clinical biochemistry laboratories in hospitals and medical colleges. She is a technical assessor, biochemist since the past 5 years. Over to you, Dr. Vijaylakshmi.
Thank you, sir. Thank you for the kind introduction. A very good afternoon to one and all here. At the outset, I would like to thank Mindray, especially Ms. Kshama, Mr. Anil Mikhija, and Mr. Farid for supporting us and for conducting this. Thank you. Now, it looks like a theme for thyroid function test, though no theme was given. I'm sorry about that. But had I known this earlier that there are 3 speakers for thyroid, I would have probably taken up another topic. So my topic is overview of thyroid function test, a biochemical perspective. So objectives are synthesis, physiology, thyroid function test, and a small note on thyroid disease in pregnancy, a small note on euthyroid sick syndrome, and the role of laboratory in diagnosis. So this is the thyroid follicular cell with the sodium iodide importer here. These are the sodium iodide importers. Thyroid peroxidase. So the iodide is transported through the sodium iodide importer and it is organification occurs and the thyroglobulin is iodinated. The tyrosine residues of the thyroglobulin are iodinated and this is the thyroid peroxidase which is responsible for the organification of iodide. Propyl thiouracil blocks iodination of this thyroglobulin and thereby affects and causes hypothyroidism. This is the mechanism of action of propyl thiouracil. It blocks the iodination of thyroglobulin. Perchlorates and thiocyanate which are present in the cauliflower, cabbage, they inhibit the uptake of iodide. Then coming to the action of TSH, the TSH binds with the receptor and then the thyroid peroxidase, as we all know, as we have discussed in the previous slide, it causes organification and then iodination of tyrosine residues of the thyroglobulin occur. And the T4, this is the thyroxine, T4. Mostly this is not the active form. We all know the biologically active form is T3, which we get from the T4 by the action of the enzyme deiodinase. So T4 is deiodinated to T3. It is 3,5,3 prime is a triiodothyronine is T3 and 3 prime, 5 prime, 3 becomes reverse T3, which Sain sir was talking in the morning about reverse T3, which increases in euthyroid sick syndrome. And this reaction is very important in that when deiodinase is inhibited by steroids, what happens is the T4 is not converted to T3. So this is the clinically relevant point, so which I wanted to stress upon. Then we all know, as we are all very familiar with this physiology of the secretion of the T3, T4 and the negative feedback it has on the hypothalamus. So the thyroid releasing hormone released by the hypothalamus stimulates the pituitary to produce TSH, which acts on the thyroid gland, on the butterfly gland to produce T3 and T4, which inhibits the pituitary and the hypothalamus. So, now coming to the algorithm, when the first screening test we do for thyroid is TSH. When the values are between 0.3 and 5.5, it is normal. But if the value is less than 0.3, then we go for a free T4. And this free T4, if it is elevated, it is hyperthyroidism. And if it it is normal, we do a free T3 and then review again. In case of this hyperthyroidism, so this is how, when the TSH values are less than 0.3, this is the algorithm we will follow. And when TSH is normal between 0.3 micro international units per ml and 5.5 micro international units per ml, we just review the patient after 6 to 8 weeks. I mean, if it is normal, there is nothing to worry unless the patient has some disturbance. Now coming to TSH, which is more than 5.6 micro international units per ml, we do a free T4, and if it is normal, or it may be reduced. If free T4 is normal, we go for anti-thyroid peroxidase antibodies and monitor again in 6 to 8 weeks. We all know the effect of thyroid peroxidase antibodies, and also we can do anti-thyroglobulin antibodies. So thyroid disease in pregnancy, this is a unique entity. TSH screening is indicated in women who are planning pregnancy or are in early pregnancy. The TSH that should be aimed at for these pregnant women is 2.5 micro international units per ml. TSH may be suppressed in the first trimester of pregnancy. Already this was told by Dr. Sain and also Dr. Suri also. So I request the audience to answer this, to just interact with us. Yes, why is the TSH suppressed in pregnancy? Why is the TSH suppressed? We'll see the next slide. Thyroxine requirement increases in pregnancy by 25 to 50%, and in the first trimester we should aim for a TSH between 0.5 to 2.5. So here TSH, in addition to TSH, human chorionic gonadotropin, which shares the alpha subunit along with TSH, FSH and LH, it increases in the first trimester of pregnancy, as we all know. So because of this, the TSH is suppressed in the first trimester of pregnancy, and we should aim only for 2.5 micro international units per ml that is a TSH value. So this is the HCG. After delivery, most women need a decrease in thyroxine. Postpartum thyroiditis is seen in almost 5 to 10%, and TSH is again advised between 3 to 6 months, and it is treated accordingly. Thereafter, annual testing is advised in pregnant women. We all know the normal ranges. And coming to this unique entity again, euthyroid 6 syndrome, hypothalamic pituitary thyroid axis is affected by non-thyroidal illness. It is acute and it is reversible. In acute febrile illness, in post-myocardial infarction, in post-surgery, in renal failure, cardiac failure, uncontrolled diabetes, malignancies, we can see this euthyroid 6 syndrome where there is no thyroid illness. It's a non-thyroid illness affecting the thyroid values, and the clinician must be, or the physician must be very much aware of this entity, and it is seen in 75% of the hospitalized patients. Here the TSH may be normal or it is also reduced, and free T4 and free T3 are reduced. Ideally, thyroid function tests should not be performed during non-thyroid illness, like all the illnesses we have just discussed. Abnormal results should be interpreted with caution in hospitalized patients. TSH normalizes in most of the patients after the acute phase, and no thyroid treatment is required during this. And this, we all know, this is luminescence. So we see, this is bioluminescence, and how we are assaying this thyroid is by the chemiluminescence. A similar luminescent product is the end product of all hormone assays, tumor marker assays. So this is the chemiluminescence after the addition of hydrogen peroxide. And we all, as biochemistry personnel, we are very particular about the quality control. This is the IQC on our Beckman. Equa also is followed, so which should be giving confidence to the clinicians and physicians. These are the, and this is the most important slide I want to talk about, because we have a few clinicians here. Provisional clinical diagnosis enables laboratory professionals to achieve the desired results. Most clinicians think when we ask about the history, they think that we want to manipulate the values. It's not so. Our strength is our IQC, our Equa. It is nothing else, but it is just to understand what the clinical history, just to correlate with the clinical history and never to take the history as such and manipulate the results. So, in fact, I have an interesting story. Since we have some time, I want to talk about this. We had a medical student who was just 17-year-old, and as a part of master health checkup, which we do in our central laboratory for the students, her alkaline phosphatase was 900, and the physician blames the laboratory. Madam, you are giving 900 alkaline phosphatase for a young girl of 17 years. Then I told them, sir, can you please send the girl to me? And then we have taken a fresh sample and we have processed again, just in case there was a sample swap or whatever. So when we have done that, again her alkaline phosphatase was high, our IQC was good, and the Equa for that month was also very good. So there was no reason to suspect our equipment or our reagents. So, but now the history from the student herself, then I asked her, did she have any fractures earlier? No, madam, I didn't have any fractures earlier. Then, do you have any history, then could she be pregnant, which is a delicate matter for me to ask. Alkaline phosphatase is also elevated in pregnancy, which I dare not ask the young teenage girl of 17. Then, after further evaluation, I learned that she pops in vitamin D tablets randomly because her physician told her vitamin D is having a lot of benefits, and to study for your NEET exam, you have to pop in vitamin D tablets. So this vitamin D tablets has increased her alkaline phosphatase, and this history cannot be forthcoming from anyone. The physician also will not ask her whether she is taking any other tablet. So sometimes it falls on us, but I request the physicians and the clinicians also to take the history. Please don't think that the laboratory is giving a wrong result. We have our own ways to come to a result. For us, our IQC, our Equa is our strength. But at the same time, we require a clinical history. And I think this slide conveys everything. Provisional clinical diagnosis enables laboratory professionals to achieve the desired results. Thank you all.
Thank you, ma'am, for that excellent presentation. If there are any questions, I'll throw it open to the House. If there are no questions, I'll ask a question myself. Ma'am, have you tried using TSH on another analyzer apart from Beckman? And have you noticed any significant variation between different analyzers? And if yes, then how have you addressed this issue?
I have also used mini-vidas. So in the very beginning of my career, I have used mini-vidas, and then later we have used Beckman. Also, we have used Advia XPT, and also presently we have Roche as well. And in mini-vidas, what I observed was, typically in the first pregnancy, the values were low. But I didn't see this in other equipment. I don't know why. This is my experience. Maybe you can throw more light on this, sir.
So my question was not vis-a-vis pregnancy. I'm just saying variation between TSH levels amongst different platforms per se.
Definitely because of the, as just now in the morning there was one discussion on streptavid and biotinase. The methodologies from one instrument to the other, they definitely are different, sir, but I have not done much work on that. If you have observed, sir, please enlighten the audience also, sir.
So we have done between two different manufacturers. I would not like to take name at this platform, but the variation between TSH was more than 30%. And when I looked at international literature, there is, difference as high as 50 to 70% amongst different analyzers, and there is something known as harmonization of TSH that is being tried but not yet fully successful. So what I would recommend is that if in your laboratory you are using more than one analyzer, then you must establish a Deming regression curve and a correlation factor amongst those analyzers, and at least apply those factors in one of the two machines. Because
True.
otherwise what is going to happen, your patients on medication are going to keep coming to you after every 15 days, 1 month, and you would not know on which analyzer you have done the previous reading, and that could misguide the clinician to either increase or decrease the dose of the L-troxin.
Very true, sir. Only recently we received the Roche. Earlier we had the Siemens equipment. Definitely we still are in the process of harmonizing the equipment. But we have done that with Mindray clinical chemistry analyzer. We would all, and we had, the reagents we used were not dedicated reagents. We used different reagents because it was an open system. Then it so happened that IQC was very good, but our EQA never was matching with the Biorad EQA result. So we had a factor. So now the creatinine value which comes out from the equipment, we call it creatinine. And this creatinine which comes out, we said it is creatinine T, and we had a factor with which it would be multiplied. And so all the patients would get the benefit of giving this. So there was no discrepancy in the accuracy because of using this creatinine T.
Can I add something, please?
I would like to put some that it is very difficult to basically see whether there is a difference in TSH level in different platforms. The major problem, major hindrance in that is you don't have a similar kind of reference ranges. Different companies have different reference ranges. So similar kind of problem was there with the HbA1c long back. So with the NGSP criteria and all, now you have a reference range similar CV percentage. So now you can evaluate between different platforms. So similarly now it's coming gradually with creatinine, but as of now there is no same reference range for TSH. If you take about Abbott, the reference range is much broader. If you take about TSH of Roche, it's much different from Beckman-Coulter. And if your reference ranges are different, how can you compare with the different platforms? They have to be different.
They have to be different.
Their 4.63 is the uppermost range to call it a non-thyroid, and another platform is 5.2. So even in reference range, if the difference is around 10-20%, how can you evaluate it different?
How can we get the confidence on that? Maybe because I personally feel Biorad EQA sample, they give peer groups. So that is a better indicator. So that's how we compare. We compare with that particular equipment and methodology, and only then we satisfy ourselves and the patients.
I would like to add something here, what Dr. Suri was saying. I have two analyzers of the same manufacturer. And I was having an issue regarding correlation, what sir you were saying. They're exactly the same platform and the BRI is the same. Everything is identical and still there is some variation. Then I looked up the current CLIA guidelines and they are saying that up to plus minus 3 SD is acceptable. So that much variation occurs.
Yes.
So I do the regular harmonization of TSH in both these analyzers of the same manufacturer. I'm not taking the name. And always the value is coming within plus minus 3 SD. So it's a big variation which is acceptable, and I am uploading EQA for Biorad from both these analyzers. and the Z-score is fairly comparable.
That is the same manufacturer, ma'am.
Yeah, same manufacturer,
when-
but even then the variation is still occurring even for the same
But
manufacturer.
when you use a different manufacturer, the variation
it is
the variation is so high that it will not fit into any acceptable CLIA limits. Also, it will not fit into any acceptable biological reference intervals.
Absolutely, absolutely.
And especially the problem will occur when the patient will be borderline normal and subclinical hypothyroid. In that particular bandwidth, a lot of differences will occur amongst analysts.
Absolutely, sir. It becomes like apples and oranges. You cannot compare apples and oranges.
Correct.
You can compare apples of one company and another, that much.
That only happened because there is no gold standard.
Correct. So the harmonization attempt is globally has not been successful till date, sir.
So that is not possible.
Yeah, but this has to be conveyed to the clinicians because otherwise you'll keep coming back with answers like your report is wrong every third day.
See, it happens what if the brand A is somebody is using, who is bound to give you a more or less borderline normal TSH, and you are giving a borderline abnormal TSH, always patient loves to see the normal report. So you will be crucified by any when you get
So the one who gives the higher TSH will be crucified.
No,
Hello.
India
Looking at
is-
the time constraint,
One-
can we
one-
wind up this session and
one question, ma'am.
Oh.
In the ISO 1518 in 2022, there is something called commutability that has been discussed. I am not sure whether this is related to the intercomparability between the.
So computability is something.
Commutable.
So there is an attempt globally to harmonize the TSH level at least among the 10-12 major manufacturers. So far, it would require, all of them to recalibrate all their equipment. The one who's on the lower end of the spectrum will have to move a little to the right. The one who's on the higher end of the spectrum will have to move a little to the left. But so far, that attempt at synchronizing at least the major manufacturers of TSH globally has not seen the light of the day. Ultimately, we'll have to come to a point where we harmonize amongst all manufacturers. Otherwise, this is a problem we'll keep facing day in, day out.
So what I say is the peer reporting in the ecosystem should be avoided because the peer reporting makes the feel that the equipment is correct, the result
sir,
is
all
correct, but it
equipments
is not clinically relevant at all.
No, sir, all equipments are correct, sir. The peer.
All equipments are correct as far as the equipment and their methodology is
Yeah,
concerned.
yeah.
The problem is clinician has no clue on the difference between these equipments.
so at least-
So this is going to be a big problem if it is not addressed
There are
appropriately.
three
But
things.
as per the best definition of a PT, any PT program, the best comparison is when you are comparing with your peer.
Correct.
But as far as the clinician is concerned, this is going to be a big problem.
So there are
and
three-
the patient is concerned, this is a big problem. I think ISO is trying to address that, but maybe in future it will be correct.
No, sir, there are some good laboratory practices that we can all convey to the clinician. A, preferably get the TSH done at the same point of time. If today you are getting at 1 p.m., get tomorrow also at 1 p.m. Second,
but the problem
if,
is,
no,
the
no,
problem is clinician is almost at least 25% of the clinician is not satisfied with
No,
the
sir, that is another
result.
problem that we can't address in this
Yeah,
forum.
then what happens is he will try to find out and
sir,
send
may
it
I
to somewhere
request,
else.
due to the time
That is-
constraint,
Sir, we will
is
take
it
offline.
possible